So again, thank you so much for having me here. I've really enjoyed my almost 48 hours getting to know you and your department. And I'm very pleased to have the opportunity to get to know a few students as well while I'm here. For those, I see many faculty members here, so just so that I give you a sense of what I wanted to bring in my presentations. Yesterday was a kind of academic presentation that I would give in a media studies or visual culture conference type setting. It's to give you a sense of the research that I'm engaged in, but it's not the type of presentation that I would direct to medical students here, and that's why I thought I have the two opportunities. So today's more the type of teaching activities that I would like to engage in, even though this, sometimes they're the same content, but not necessarily presented in the same manner. So before I begin, I want to get a sense of who's in the room. Now I know all the faculty and members that I have met and so on, but medical students, yes, thank you. Okay, and are you all in the first half of your program? Is that correct?
I'm in the first year.
In the first year?
And I'm a second year.
Second year?
I'm third.
Oh, you're in third year, okay. Wow, good cross-sampling. Great. And because I know the profile of people interested in this department is so diverse, I would like to ask all of you to let me know if you consider yourselves cultural producers in any way, if you are musicians, if you are writers, if you are artists, if you do just, it's a small group so everybody can see, but
how good do we have to be to consider the product?
Sorry?
How good do you have to be?
Yeah, if you consider yourself,
Does
that's the
DJ
criteria.
count?
DJ,
DJ
okay.
count, DJ count, that's music.
Okay. I heard you were a very good cook, so that's awesome.
Oh, no, I didn't mean that I was a DJ, I just meant that.
We're curious.
I can match that.
Okay, so yeah, not unsurprisingly, I think many of you raised your hands. I want to tell you a little bit about myself before I actually go into the conversation that I wanted us to have. So in my introduction, it was mentioned that I've done some work on autopathographies. I've done some academic work on it, but I've also done some curatorial work. And these are exhibition views of a group show that was shown in Innsbruck in Austria. And I've looked at autopathographic practices, that is to say self-representations tied to illness in the visual arts. And what I wanted to focus on in this exhibition was the fact that it occurred to me in studying these practices that visual autopathographies are often collaborative, that there's an interpersonal dimension to it from the production process. So unlike an illness narrative that might be written in isolation by the patient and then later on read by someone else, so there's like a communication process that's in two steps. What I found really interesting about autopathography in the visual arts and in the performing arts as well is the fact that in the very creative process, illness becomes an occasion of sorts to come into meaningful contact with someone else through the creation process. And that's really unusual and specific to these artistic autopathographies. The other element of my background that I wanted to introduce you to is my alter ego. So I spent a lot of time working as a clown doctor. A real clown, not a real MD doctor. Unlike Patch Adams, who I'm sure many of you have heard of, who's the real doctor, and a real clown. Why is this experience important to me and important to what I might bring in a teaching context here? Well, it's because I've been in contact not just with patients, but also with professionals in different types of healthcare settings. So from hospitals to readaptation clinics to long-term care facilities and so on. And what I really learned from this experience, it's all based on improvisation, no set show. It's not like you're putting on a show and coming with something ready. You're responding to the situation in that specific context at a given moment that might vary from day to day with the same patient and so on. So we qualify this work as relational clowning. So I mentioned my interest in the collaborative aspects of autopathography in the visual arts. Here, what really stuck out for me is this interpersonal element that was the focus of our clowning interventions, if you will. And it made me also, this kind of field experience made me aware of how different people's experiences are in healthcare environment, both from the perspective of patients, whether they're elderly people with dementia in a long-term care facility who have limited contact with visitors because they're isolated, versus someone who's just going in to the hospital once in a while for a blood test or something like that. Whether it's that or the perspective of nurses, the perspective of maintenance workers, the perspective of doctors, and so on. And I think I was speaking to Dr. Gasho about this, the fact that maintenance workers often have such an important role to play in terms of the patient's experience, just because they're around. And some of them, might make jokes, and some might just do their job, but patients interact with maintenance workers quite a bit. So that's the experience, the elements that I would bring from that experience. The project that I'm working on, and I'm going to draw from this today, is looking at art in healthcare environments, focusing on art that's done outside of a therapeutic context. So here, there's a recent mega hospital that was built in Montreal, and these are the kinds of choices they've made for public art. You can see a strong medical influence in terms of the themes in some cases. And what I find interesting about this research is that through the art choices that are made, I get to understand a little bit how the healthcare environment positions itself in relation to the community at large, in relation to society at large, and what is the role that art plays, also in terms of the hospital's image. And so I'm going to be using examples from this project to help drive a conversation that I'd like to have with you today. And I would like us to focus on, to begin by considering the healthcare environment as a space of encounters. And I will specify that. When we think about encounters, we generally think of two sentient beings coming together, two people coming together. But I want us to expand that definition a little bit and think of the encounter not just between two sentient beings, whether it's people or people and animals, for example, but to think of the encounters we have with spaces, with technologies, and with different people in the healthcare environment, and how does that affect our experience of the healthcare environment. So specifically, the through line of this conversation will be to think about, well, what are the human, but also the non-human actors, the agents, that can help to shape our encounters, or that have a hand in shaping our encounters in medical environments. And so, to begin this reflection, I'm going to ask you to take a look at something. So, this is a work that's called Paths Crossed. It's from 2013. It's installed at Ashkenazi Health in Indianapolis. It's by an artist called Aaron Stephen. I can tell you that it's made of wood and that it's approximately 60 feet long. And so I invite you to observe it as if you were getting ready to make a diagnosis.
So it's in a hospital?
That's right.
Is that the main entrance?
Yes.
It looks like what healthcare is like these days.
Interesting. Okay, now I'm gonna the image away. Please, what did you see?
Well, it's just very complex and convoluted, and you walk in and how do you go to pre-op and how do you get to labs, and confusing.
Roller coaster ride.
Roller coaster ride.
Hershey Park inside.
Hershey Park inside, okay.
A lot of steps along the way.
A lot of steps along the way.
It evokes double-stranded DNA in the
Yeah.
coils, and also kind of a ladder.
Yeah.
So you're going somewhere, but it's also got that scientific DNA type look, but it's not organized, it's sort of chaotic DNA.
Chaotic DNA. Okay. What did you see?
In some ways, because of its chaotic nature, it kind of represents the patient mind, perhaps. Like, you're afraid and you're not sure. It might add to the anxiety of the place.
It might add to the anxiety of the place.
Possibly.
It's also remarkably bland. There's no color other than
Yeah.
the basic one color. It could have been much more playful if there were a lot of colors.
Okay.
I didn't find it chaotic, which feels like a negative word for me. I just found it curvy. You know? I mean, you could put positive words on it too. Interwoven, you know, like spiraling. I know it was not negative.
Forward motion.
Yeah.
I was
Thinking of the
thinking
ocean.
forward motion. Oh, the ocean. Okay. So
Yeah,
like a
like
wave.
waves.
Okay.
I
What
was
else did
thinking
you
it
see?
reminded me of the Olympics as well, but not necessarily chaotic, more that there was other things coming into it and maybe making it confusing, but also making it like a part of the bigger understanding.
That's the one thing that I was trying to view it from the patient standpoint, coming in here and looking at it. Because of its enormous size, it's sort of the effect in a cathedral where a person feels smaller in the presence of something larger. And I think I thought about how a patient already shrinks, you know, kind of as a person when they walk into this hospital, they're already afraid. There's a shrinking of the person's energy and they're afraid what's going to happen. And then there's this larger thing in front of them. They don't know anyone on the other side, perhaps, in the hospital. So, very interesting.
The monumental.
Mm.
What else did you see? Did you see anything else? Do you want to respond to anything that was said?
So I wasn't sure if it was crossing of paths, is that what?
Paths crossed.
Paths crossed. This is kind of weird, but you know that they obviously have to come together from different places and then they intermingle. But then they all sort of go off on their own, and that seemed kind of sad, I guess I thought.
They're lonely.
I realized that what?
They're lonely. The
Well,
ones
yeah,
at the end.
and I'm not sure, I don't know why I thought that, but it just seemed like it might, I mean, because certainly people, the paths cross, sometimes, you know, I mean, you might see one patient, or you might interact with one other professional, or you might never see them again, that's possible, but, yeah, I guess the question is, what's the message?
Okay, but that's interesting because I want us to look at it again, and you're actually pointing to where I wanted to go, which is I want to invite you now to read this as a metaphor for the types of encounters that we experience in healthcare spaces. Now, that's not to say that this is what the work means, you know, but I think, as you suggested, it could be a metaphor for one person's experience through the medical system, as it were. Is that what you were, you know, they come in,
Yeah, that was sort of what I was
there's
getting at.
different people involved, they leave, their paths cross, then they go, okay? Are there?
I feel like we could also be in a psychology class right now, right? Because we all see ourselves. And I mean, I think what we see in there comes from our own experiences. So I probably wouldn't have said, navigating complex medical systems, because that's not my lived experience.
Okay.
And I'm having a good day, so I see it as
Yeah.
But we can
Okay.
change it.
No, but that's
So,
interesting.
like, so it's just so very subjective. It means
Yeah.
totally different things to different people.
But that's a good point. So
That's
I
the
said,
point, isn't it?
Uh-huh.
That's kind of the point,
Yeah.
isn't it?
but I did invite you to observe it as if you were to make a diagnosis. So I will follow up on that by saying, what can we use from this work as it is, from the information we gather from this work, to come to conclusions about it. So you evoked the title that says Paths Crossed. What about the form? So what is it made of? I heard the word ladder. Yeah, these are ladders, right? What about how they're being used here as compared to a functional ladder? What's changed?
It is interesting too, that's made of wood, so
It's made
it's a
of wood.
rigid structure, or like fairly rigid structure, I guess, that until it's worked into a different shape.
Yeah.
But you could have done, the artist could have created this with a different material that would have been easier perhaps to like make into that helical shape as well. It's also really simple and it's
Simple,
a natural resource.
You know, ladder usually take you from one place to another, and, you know, from the ground up higher or something. And these have sort of not taking you anywhere. It's ladders to nowhere, and it's not a direct route. You think of a ladder as the most efficient way to get from linear from point A to point B, but this is taking you in a roundabout way, and then you end up nowhere because it just ends in the in the middle of the
Yeah,
room.
I think of it, I look at it and I see my son trying to get up there. Go, so for him, it's something to play on.
Thankfully, it's suspended. I don't think he'd be able to get up there. He might find a way.
It's very bothersome that it ends, that, you know, there are dead ends here.
Yeah.
And it's also, it's above, you're looking up at this.
Yes. Yeah,
And,
yeah, yeah.
and also, I would wish it would be kind of, it looks like it's horizontal. I would like to see it spiraling upward.
So
rather
that's
than-
really interesting.
Rather than, it looks like, unless at the end, maybe it's lower at the far end, I don't know. Maybe it's spiraling upward, but it doesn't look like it is.
It's
So you would
horizontal.
hope that there would be
yeah.
hope going up. You would hope that there wouldn't be, and that's realistic, there are dead ends, but you would hope that the image, when you come into the hospital, would not be that there would be a dead end somewhere.
But this is one of the key things right in there. The ladder you mentioned, you're going from point A to point B. Usually the ladder, there's a notion of ascension, or you know, and when we talk about climbing the social ladder, we're thinking about improvement. And here, we've kind of flattened this hierarchy. And then the ladder is not being used as a ladder, but it's showing evolution, progression, maybe elements coming together. So again, if we go back to thinking of this as a metaphor for our encounters in the healthcare space, you know, if we think of the health recovery effort, and if you're going with a model of ascension, where you're getting to a point of health, you're not necessarily representing the majority of healthcare experiences, right? There's health management, but not necessarily full health recovery. So in that level, we can think of this also metaphorically for health as a spectrum, a continuum, and not necessarily a fully able-bodied and healthy and suddenly diseased, and that there's only those two extremes. So that would be one of the ways in which we could read this. And I mean, I'm conscious of time, so I'm gonna move forward, but of course we could go from many of these themes and then discuss further. But one of the things that you mentioned in your comment was the many encounters with people, right? That from the patient's perspective, the healthcare, if the patient is one of these winding ladders, and then you see all the ladders coming together and not necessarily joining the patient directly, each ladder has its own function, and they all try to head in the same direction, but not necessarily taking the same path or in the same way. So this kind of synergy that's not always in unison. We could read it in that way too. But I mentioned that, you know, I want to consider all these different factors that come into play in terms of our encounters in the healthcare experience, and one of them is space as a really defining element of our encounters. And I want to ask you, if you take a look at this, I'll situate you. It's the winning architectural design for a recent hospital building in northern Vienna. And this is the architectural rendering. And just, you know, quickly take a look at this scenario, which is an invented one, right? It's a rendering, it's not a real image. And maybe you can name some of the encounters that this space is facilitating. You know, what are we shown in this image? What kinds of encounters are we seeing? What people are involved?
Humans and nature.
Humans and nature. Okay, interesting that that's the first one that you picked up on. Yeah, rather than being that we see people in the foreground, but we also really see this young girl looking out. We see these huge windows that show that the hospital is open onto the natural space that surrounds it, that the natural spaces is being integrated into the terrace and so on. So yeah, we do see a lot of modern architecture design trying to bring in these natural elements. I noticed that you have a garden here as well, and that the new hospital building has a green roof as well, so similar type of space. And then what about the encounters between people? So this is a kind of a lounge area. Who are the people who are seen mingling?
I'm struck by the fact that some are dressed professionally and some are dressed casually, so it doesn't create this typical traditional Krankenhaus environment. Everyone is dressed in white and somber. It's almost like a mall. People encounter one another in a semi-professional way. It
Right.
changes the environment, creates a kind of a non-sickness atmosphere.
A non-sickness atmosphere, yeah. The convivial space where you can gather around and look at the space outside the hospital, that the hospital isn't separated from that outside space. Does this look to you like a realistic picture? In the foreground, we've got these two individuals who are having a nice chat.
They're transparent.
They're transparent, yes.
People are happy. Which
People are happy.
You don't generally tend to see in hospitals. People are stressed out and unhappy.
The furniture is casual.
The furniture's casual.
I like the grouping of the furniture. It looks like it would allow for some nice conversations between people. That
Yeah.
there's really places to kind of gather.
Do you foresee a hospital like this? Does this look like an environment that is familiar to you, that you would realistically see people working in? Or is it more of a utopic picture?
There's a hospital like this in Indianapolis,
Oh, yeah. Okay.
Clarion West, which was built with similar sorts of, human nature,
Yeah.
open space.
Right. So, yeah, a lot of contemporary hospital architecture is building on these notions of healthy design, which is this idea that the design of the hospital environment can support the health recovery process. And sometimes that can mean very pragmatic things like reducing patient times in the hospital. The research on that is limited and is contested because some of the original research wasn't reproduced, so it's questionable whether it's reliable data. But it's nonetheless informing a lot of choices that are being made in healthcare architecture, and from what I can tell, here in Hershey as well. What I find interesting in the conversation in your comments is also, you mentioned it being a casual space, it being a space that connects with nature and so on. And one of the notions that comes up here is this idea that the hospital space doesn't need to be separate from the rest of your social life environment. And an extreme example of that is a recent phenomenon in France where a French hospital is to open a wine bar for terminally ill patients. And so here we see a radical conception of the kind of social space that a hospital or a hospice could be. And very culturally specific as well, right? I don't know that a wine bar would be the most appropriate thing to bring into a hospital in North America. There might be something else, a basketball court, who knows? But in France, Starbucks, yes, no, but you say that in jest, but that's actually a fact, actually. That's really conscious planning from architects to build in these cafes and I think someone here mentioned the airport, shopping malls. You said a shopping mall, right? There's similarities between hospital architecture, shopping mall architecture, and airport architecture. And the similarity between hospital and airports is wanting to make people feel at ease and not anxious before they board a plane, and not anxious before they go get their blood tests and so on. Okay, what about missed encounters or non-encounters in the hospital? And I'm thinking, what about elements that I mentioned, the actors, human or non-human? I'm thinking about technology. How does that change our experience of the healthcare environment, but also our encounters with the professionals and with our colleagues and with our patients, etc.? So here I brought in a still from a video by Yuri Ancarani, who is an Italian filmmaker, who in 2012, I believe, made a documentary film about the famous Da Vinci surgical robot. It's a 25-minute film. I haven't seen it. I've only seen excerpts because it's only screened in like film festivals and the like, so I haven't had the chance to see it. But I do remember seeing an excerpt that stuck with me because this robot, it was like a lot of photographers here, so it was like a brightly lit robot against this dark background, and then you see its arms kind of moving in this very lyrical way, and then it takes on this kind of aura of being a beautiful object, awe-inspiring. And then there's the flip side with technology, which is the potentially alienating dimension. That, oh, how strange, it's bionic, it's like, where's the human? And as you probably all know, what happens with surgery with this kind of robot is that you don't actually, as a surgeon, you don't physically come into direct contact with the patient. There's no tactile contact. It used to be that the instrument, there was barely a threshold between you and the body in a way. The instrument, the scalpel or whatever else, does mediate or come in, in between contact. But this is very different. If you think of telemedicine, you don't even need to be in the same space geographically as the patient. So this really changes the types of encounters that you have in medical spaces. And I find that this is happening a lot, not just with the technology like this one, but also with all these remote technologies. I've spoken to some of you about this in the past couple of days, like these, the quantified self, if you guys are familiar with tech language, this idea, if you have a Fitbit or some sort of fitness monitoring device, it takes all this data about when you sleep and your heartbeat and so on. I know that there are many apps being developed that go right into your iPhone. You can take your blood sugar levels. That data gets collected, sent immediately to your pharmacist, who's alerted in case you need an intervention or something like that. All of these interventions or these changes, technological changes, mean that your experience as a patient and your experience as a doctor, the ways in which you come into contact with each other has changed. So encounters with technology, but also encounters with data as being the representation of the patient and so on. I'll give you a specific example of this. I don't know if any of you have encountered this fellow, Salvatore Iaconesi. He's done a TED Talk and everything. He's gotten very famous, but he's an Italian artist and hacker and designer who had a brain tumor. And I will let him explain what his experience felt like. So he writes, when you have cancer, you disappear, and you are replaced by someone or something else, a patient. This is a strange being, entirely made of data. Blood exams, images of your body, lab values, diagnoses, and more. But this data is not you. It's not as complex as yourself. You are suspended from the world around you and you become encoded through a set of data. Nothing really speaks to you anymore, but rather about you. So I know there's aficionados of graphic medicine. His story recently came up 3 weeks ago in a graphic medicine project called The Scanner Constantly, which is by someone who has the same tumor that Salvatore Iaconesi had. And what he experienced is based on his own account is as a patient, he was in the hospital, he was treated for his tumor, and then when it was time to leave the hospital, he says, I want to have access to my data. I'm a hacker, I know data. I can, He was denied at first for insurance liability reasons. But he's like, this is my data. This is my medical data. So he managed to convince the hospital. And then he realized that the data that he was given, which was his, in a way you could think of it as a portrait of him. It's a form of portraiture, right? It's a knowledge about a human being, but a numerical form of knowledge. The image that he had of his tumor was coded in a professional, specialized image code from the medical field, which an average user does not have access to the tools needed to see that image. So as a hacker, he hacked into the file, made it into a JPEG, put it online, and he developed a project called opensourcecureforcancer.com. Put all his medical data out there. And that for him was a way of reclaiming his personal identity. Because what does a hacker do? They liberate data in a way. So that was his take on it. I bring it up, and I'm sure there's a lot to discuss, but I don't know in terms of the format of this. If you wanted to leave time, looking at you in terms, if there's, if you wanted to leave specific time after to talk about the presentation. Yes.
So why don't you take it to 15 till?
Perfect.
If you
perfect.
want to.
Yes, that's perfect. Exactly. So his experience in a nutshell was the shock of the encounter with himself, not as the person that he knows, but himself as data, and then wanting to bring that data back out of the hospital. And if we had time, we could talk about how the hospital space has been viewed by some as being a separate social space from the rest of civic society, let's say. Architecturally, architecturally, hospitals were also often made on the fringes of the city, protecting from contagion and so on, but this idea of a separation between everyday, quote-unquote, normal life and hospital life, which is exceptional, outside of normal life. And there's a desire to break that conception, I think, quite explicitly from his own account of his experience and what he does. Okay, I want to present you another example of the role of, let's say, non-human factors in our hospital encounters. If you speak French, if you can read French, don't take a look at the text. If you can't, that's great. I want you to take a look at these bags. It's actually one bag with two sides. And tell me, where do you think, this is a bag that was made for hospitals? Do you have any sense of where this might be used, or in what kinds of situations a bag might be a useful object in a hospital?
Hold somebody's clothes when they're admitted.
Yes?
Or when they're discharged.
Or when they're discharged,
Yeah.
okay. Yes? What kinds of bags are usually used for that? Plastic bags. Yeah. Okay. So this is a really simple object, right? A bag. It's an inexpensive, and it's a functional object. I'll give you the story behind this bag. It's designed by an artist designer who's based in France and Germany. And he explains birth and death are daily events in clinics and hospitals. Whereas we celebrate birth as a happy event, we are, however, often destabilized in the face of the death of a loved one. We refuse for death to be part of our lives. And so it's frequent that in hospitals in France, Germany, or Switzerland, that the clothing and the personal effects of loved ones who are deceased are given to people in a plastic bag, possibly a garbage bag. So Raoul Marek thought, wow, this is a really crucial moment in a person's life. And this gesture of putting in the personal effects in a garbage bag does not live up to the importance and significance of that moment. So he designed these bags, which had the dual function. On the one hand, they can be used in moments of birth, because often you give families, new families, you give them samples and documentations and so on, many things that they can bring home with them. And on the other hand, the same bag can be used at the end of life to return the personal effects. And it's the same bag that has a rising moon on one side and the descending moon on another. And this, in terms of thinking about our encounters with objects and how that affects the experience of the healthcare space, and how the object can be, such a small gesture can stand for so much in terms of the attention and care that's given for what people actually experience in the hospital, which is often these crucial moments of existence. if we're talking about encounters with, it's also about encounters with life and encounters with death that are poetically brought together in just this little, very simple, unassuming object.
Do you have any record of how people responded to them?
I don't have any record.
Comment.
There's some information available online. I don't know that there was any specific follow-up. I think also from staff, it would be really interesting to get their perspective. But I don't know of any extended documentation of this.
Are the bags charged?
No.
Okay.
Yeah, but it's Europe, so.
Here we charge for everything, Band-Aids and whatnot.
But the garbage bags cost something too, right? It's a negligible cost.
Exactly.
But it's also possible to produce bags that are a really minimal cost as well. It's a little gesture, and this gesture comes because someone just paid attention to this fact, and you wouldn't necessarily have come up with it without having had first-hand experience of how significant that little gesture can be. All right, so encounters with objects, as I mentioned, so leading to, that can evoke more existential type encounters. Did you want to say something? No, okay. Okay. I'm going to screen this, and then we'll talk. Okay. Take a look. It's another type of encounter. Maybe you can tell me what kind of encounter this is. So, does this evoke any types of encounters? Does this trigger anything? I know we just saw a small little excerpt and it was quick. We've spoken about encounters with spaces, with objects, with other people, with data.
The kind of invisibility or implicitly trying to be invisible, to sneak behind somebody and not be noticed.
Okay.
That little fragment's what I think. What?
That fragment made me think of the antisepsis and the lack of human touch contact, and we put on the yellow gowns when we go into rooms of contact isolation.
I mean, so it's so discordant. I mean, you just don't expect to see people dancing, performing in the hallways of a hospital, and so it's sort of jarring to see people moving in that way in that space, and sort of not knowing what to do with it. I mean, imagine if one is working in that space, not knowing what to do with that information about what are these people doing in this place at this time, and why are they there, and sort of get out of my way.
Yeah. Well, we saw a couple of clearly medical professionals who were walking by and completely oblivious.
It's jarring.
Yeah, it's jarring for sure.
On the other hand, the older gentleman is dancing with the protagonist. So there's some kind of contact and movement. He has a smile on his face. So there's some kind of deeper connection between the dancer and the patient. So the dancer has evoked something from the patient because the patient gets up and starts moving around the room.
Yeah.
So it strikes me that somewhere beyond the jarring that Michael pointed out, there's something else emotionally going on.
So if I guess something, I mean,
patient that got up to dance with
my guess, and I'd be totally off base, but that the patient, that older guy, was the choreographer and some famous guy, and then these people are, and he's a patient in the hospital. This is an homage to him by his proteges,
I think this would look so different in the pediatric ward. because the staff there would dance with them, and
Yes,
the kids
yeah.
would dance with them. It'd be so, it wouldn't be jarring, it would just be,
Yeah.
oh, fun.
Yeah, good point, good point.
Well, I just think, we're all over pet therapy, right? We bring these dogs in and, but this is a different, as you mentioned, a different way of drawing out emotions, looking at performance. And I think that's like, who would have thought? Because it is very emotive if that's what trips your trigger, right? It's, or music or,
So, you used the word discordant, and what I heard from you was something more along the lines of concordance, the synchronization. This is not a famous choreographer. This is just a patient. And I get the sense from the intervention that the patient was leading the dance. Just because I know from having done this kind of work, because this dancer does works generally in France, but came to do a residence in Montreal. I know that the work is based on improvisation there too. And so the lead goes to the partner, not to the professional.
Shadowing.
Similar, yeah. Or here it was a kind of a very concordant, mirroring kind of gesture. So this gives you some sense of, some of the elements that I would like to bring in addressing the types of encounters we have in our spaces. The next step, obviously in this context of a course, these kinds of examples would be worked through in discussion, but also in relation to corresponding literature about these kinds of interventions, so that we can also have a perspective on what this does, what this does not do, and so on, but also experience to a certain extent how it functions in this space. The next step in the process for me would be to ask medical students and professionals, what resources do we have at our disposal to help shape the encounters that we experience in a healthcare environment in the manner that will be beneficial, whatever that means to you, both for yourself as a professional and for the patients that you come into contact with. And if I may ask you to look at this video again and just maybe consider what can I also get out of these artistic experiments? Is there something to be learned from them, from their way of these artists' way of coming into contact with people, or not, as you mentioned? So here we see him following this person, following their rhythm. Here very briefly we get a sense of the space that was created during the dance and tune. You hear that moment of concordance and mirroring between the dancer and the patient. I don't necessarily have an answer as to what you can get out of this, but I think from this kind of work and other kinds of works, there might be some clues. And then, the next step would be to address those possibilities more concretely.
Well, I think some of the clues I get is just, kind of the mirroring, as you had talked about, that is, when I do my fourth year selective and we do a videotape, it is sometimes helpful not only to look at how the students are talking with the patients, but how they are sitting, whether they're pulled back or they're engaged, and what the body movement tells the patient.
Yeah, absolutely.
I was wondering, is part of the lesson of this little clip, there's something surreptitious about the dancer. He has to slide around, and it's almost seeming like it's a metaphor of the difficulty that we have of moving from one mindset, the traditional way of doing hospital life, to a more open way of like dancing with the patient. I wonder if that's kind of a metaphor. The dancer has to find a way to navigate the traditional space, and he does it surreptitiously. He looks around, and then he darts in the room, and he opens up into this freedom space where he and the man are dancing. And it just strikes me, that's one of the problems that I think that you're talking about, is trying to break the barriers the traditional way of doing medicine, caring people, moving from that to something that is in a way fundamentally different. Who thinks about dancing with patients? And yet it seems to me you're suggesting that that's not only possible but desirable. Is that correct?
I really like the way that you describe the dancer's challenge, and absolutely that if I look at the artist's perspective, you have to be nimble and certainly not get in the way. The last thing you want to do is get in the way. Whether or not it is desirable to dance with a patient, that's not my decision. I think that's everybody's decision, you know. And I mentioned, you know, the next step is to consider what resources we have and what tools we want to employ as professionals. What I wanted to suggest with references to architecture and design is to say that any healthcare space, you talk of, you know, any discipline, any practice has its set of conventions, its habits. Some of these might facilitate meaningful encounters or productive encounters. Some of these elements might be a barrier, might be something that you have to work against. That's true for anything, I think, in life. But whatever the context in which we work, I think we also have a little bit of wiggle room. And I think that's what a medical student in training can, and my sense is very much that this is what is being cultivated here, is to look at what margin, what room to maneuver is there, given my very limited time frame and, you know, brief interactions and the necessity to communicate certain pieces of critical information. What are the little elements that I can do, the choices that I can make, that make me also, you know, healthy in my professional life, for whatever healthy means to you, and that make me fully present in attending to the patient's experience. You know? So that would be the dancing.
So the dancing is a metaphor in your mind for the humanistic dimension in the doctor-patient encounter. Is that right?
Certainly.
I think as a student, I was thinking about this the third year. There are 4 elements, and they all start with S for me, that I've identified when a patient, when I encounter a patient. There are 4 elements that are unsaid. They're there for me, for the patient. The first aspect is this sense of sterility about
yes.
the environment. So we're not in the natural world. We're not in the flow of life, you know, kind of movement. The second aspect is stasis. Every sickness, every sick patient, there's a certain stasis to life. There's a certain stasis physically when you're in the hospital, and that's quite a detriment to the functionality of life, the flow of life. So if the goal is to get the person back to well-being and movement and kinesis, usually, you know, in the hospital, that's a difficult, challenging thing. But when a person is able to clinically do that, I found one of my patients taught me about stasis. This lady had been bedridden for so long and depressed. And so the other element was sadness. You know, it's there. For the patient and the provider, I see that every day. It's not subclinical, it's not depression for maybe most people, but it's there because we work in this environment of suffering. And the fourth thing was for me the sick role. We've enabled sometimes the patient's sick role and they can't get out of it. So the well-being that's outside of here. So the 4 S's that I think about from this third year, what are my interventions that I can do as a student? What little things can I do? This lady taught me that I could go on a walk with a patient later in the day when the rounds are over. Just down the hall, if you sit by a window where we can look outside. And for me, that moment really taught me, and it came kind of later in the year, unfortunately, but I think I'll carry the lesson from there. She was so depressed, and she gave me a smile for the first time in a month, because I took the time to go on a walk with her, came back and looked outside the window and asked her what she noticed out there. And it was just the backyard of our, you know, hill. So we created movement. We broke the stasis. I hope that there was some sense that we broke the sick role for a moment, where she felt like she was a person who could appreciate nature outside. Sadness, I'm not sure has changed or not. And I think there are a few interventions that are very basic, very simple. We don't have to talk
Yeah.
about it, but they're integrated part of this work. So in a way, that's my example of how one could do it. The challenge is technology took me away. I had to go hide behind the computer
Right.
and do that, which creates a barrier sometimes to actually go back to the patient in that moment. The temptation is to do what everyone else is doing.
Okay.
There's
So you
a
made
challenge.
a conscious decision to go find the patient and go for a walk.
And you left the sterility.
Yeah, yeah,
You know,
yeah.
the kind of, the computerized technical.
Yeah.
We need it, it's important, but at least in my generation, it's kind of like, if you don't do it, well, we shouldn't. So I have to do that.
Mm.
I gotta find a way to.
Mhm.
The 4 essays that I think of.
Do other people have questions or comments? So you've only been here for 48 hours?
Yes.
So you might not have been here long enough to notice this, but since you've been here, have you noticed certain objects or structures that a facilitator got in the way of encounters that we're talking about, like specifically to our hospital?
Well, I was shown the new wing, or the new hospital space, and we had a coffee by a piano player, and there's a beautiful a lounge area where you can sit and listen to really good music. So I think that's a facilitator for, I don't know to what extent, you can tell me, I don't know to what extent the medical professionals also sit there, but I'm sure for patients it must be pleasant if you're waiting for a ride home or something like that, or you've got someone waiting for you while you go in and do tests or something like that. I think that's an immediate welcoming space, and it's right at the main entrance, and so that's also something that you find in a lot of healthcare architecture, that there's an effort to make these places that are like atriums welcoming spaces, and also spaces, you'll notice one thing where there are consumer options. It's really interesting.
the shopping mall.
Yeah. And there's strategic placements also in airports for consumption, right after you pass the stressful moment of the security check. But yeah, that's another side. Yeah. If you have any other questions about anything not necessarily related to this, I'm happy to answer.
My observation was towards the end there that this isn't, it's not just a metaphor for how we interact with the patient, but how we interact with each other. And that a lot of this thinking, in terms of the dance, and in terms of, if we want a culture of respect, and we want these ideas of how we interact with each other and move by each other and concord with each other, it's totally parallel transfers, right?
Back to the letters.
Yeah.
I started paying attention about 6 months ago to what it was like when I walked down the halls and past people who I didn't know, and realized that I was not making eye contact with anybody, and nobody was making eye contact with me. It's easy, like when you and I see each other in the hall, we're like, hey, So I've started consciously trying to make eye contact with people over the last 6 months, and not make like uncomfortable eye contact, but make a conscious effort to make eye contact. And I've noticed that when I do, about half of the time, the person smiles and says hello, and it's just, it feels different walking through the halls now.
They hit your aura and it wakes them up.
Mm-hmm. Yep.
Yesterday after we left class, we did an activity where the students paired up, and one person had a bandage over their eyes, and the other people went out and came in as if they were a clinician approaching this patient who couldn't see for the first time. And then they switched roles, and I asked them to journal about it, and the inability to make eye contact was And also to walk in and not know whether to touch someone to shake their hand, because it's such an automatic thing. So I think this whole issue of space and where is the patient's space, and a lot of it too now is this notion of when you can touch and
Yes.
not touch, and if you're a male and touching a female or female touching a male, it really has become even more important. So just, they were so astute about their observations and what it was like both to be in that role of not knowing when someone was going to come in and who it was going to be and what they were going to say, as well as being a provider and dealing with the situation. And I was really impressed.
That they're
Good
they're-
observations, yeah.
So out of respect for Dr. Timbeck's time, thank you so much for providing provoking things and inspiring discussion. Thank you for that.
You're here.